Okay, hi, video 2 now. So if you haven't seen the first video, this is that was about why we do clinical reasoning and what clinical reasoning is. And now let's do a case, a classic case that comes in the door all the time in GP that you need to know about. So here's an applied case. So you've got your triage note first of all. So at the bottom, by the way, what you're going to see on the bottom here is a sort of breadcrumb trail. That is the 4 pillars of clinical reasoning. And I'm filling in just in the background in highlights when we cover that content. So just keep an eye on the bottom. So your triage note is a 28-year-old female with fatigue for the past 6 weeks. So the very first thing we would do now as a group is I would have an open question to the group saying, what is your differential for fatigue in this case? So the 28, the female, and they've been tired for 6 weeks. So what is the initial differential that you're going to come up with? So I've got a little differential here. So this differential is fatigue, and it spells fatigued, fatigueds, fatigueds. So failure of the organs, anemia and arrhythmia, thyroid disorder, IBS and IBD, and then IgA-TTG, which is celiac disease and how to screen for it. Glucose, so hypos, but also hyperglycemia if you're diabetics. Uremic states, endocrine things that are in addition to thyroid, so androgen insufficiency, so for example Addison's, and then also Cushing's disease. Drugs that can cause fatigue, thinking about your opiates, your benzos, your barbs, your anticholinergics, and the like. And then deficiencies of iron, of B9, which is folate, and then B12, cobalamin, and then vitamin D, and then sepsis as well. So you've got all of those things there together. So I would hide the differential, and I would have someone scribing and writing on the board what they could come up with, first of all. So then I would do the history. So a brief history here. Onset, it's been happening for 6 weeks. It's exactly the same all day, even after sleep. There's no palpitation, bleeding, menstrual changes, or fevers. Not happened before. They're normally fit and well. There's no substance use, no known drug allergies. They've got a partner and everything's okay, but they've had a recent job change and moved city. Their ICE is unsure and they want some help. Okay, so now I would say I've given you more information than just the triage notes. I've taken a full history. How has your differential changed? Is there things you can strike off the board here and then you could say, well, it doesn't look like the patient's septic, for example. So we're talking about those things, and maybe you could say to someone, well, do we have enough information to know that this patient isn't septic at this point? Can we definitely rule it out? How would we definitively rule it out if we weren't sure? And then someone would say, I can't remember why IgA-TTG is linked to celiac disease. And so someone would look it up and you would have a micro-teaching moment, and someone would describe to the group the process of how you need to do IgA before you can confirm the TTG, and the like. So I've highlighted some key points there. 6 weeks after sleep, no bleeding or menstrual change, recent job change, moved city. Okay, so hopefully things should be becoming a little bit clearer for you at this point. And at this point, what we're going to do is we're going to drop in and we're going to say, well, now hang on a minute, okay? Are we thinking about our biases? So this is where you stop and you say, guys, let's take a second and think. We've done our history. Any biases? Familiarity. Have I seen a couple of women in their mid-20s who've been tired recently? Am I focusing on something a little bit too quickly? Am I anchoring onto things based on these heuristics? What is my affect at the moment? Are we calm? Are we okay? Are we fine? The context, I should be in a safe room in Cedar House and everything's okay so I can think about it. Or am I in the middle of a busy clinic and half an hour behind already because I've had to deal with an emergency? Time. Is it the end of the clinic day? Do I need lunch? Do I need to pause for a moment? So thinking about these biases is super important. So here's your examination information now. So her BMI is 24, her news is 0, there's a normal physical exam, and her mental state exam is tired with a flat affect and a little bit teary. So how has this refined at this point are differential, I would say. So we've still got that differential on the board next to my PowerPoint, or in this case, Keynote slides. How have we refined here? So I'm just going to do a traffic light system here and say ambery, okay, greeny, okay. So I don't think she's in fulminant liver organ failure here. I don't think she's septic. I don't think she's uremic. It doesn't sound to me like she's Cushingoid either. There could be something going on with diabetes. She could be deficient in a vitamin. She could have another kind of anemia. Maybe there's an arrhythmia going on, but it's probably not likely at this point. Thyroid disease as well. Doesn't fit the full stigmata, but there could be enough there. Okay? So, delicious. So, let's come up with a problem list together as a group. So what are her problems? So I boiled it down to 3 things. She's got fatigue and low mood with some tearfulness, and she has life stresses on her social history. So fatigue could be biopsychosocial, low mood could be biopsychosocial, and life stresses, psychosocial probably more likely. So there's a second checklist that I'm going to bring in here super quick, which is the TWED checklist, which is a terrible name. I did not come up with it, but it's really good because it asks 4 quick questions that you can say to the group. Is there a threat to the patient or to your license? And just openly saying to the group before we close on a diagnosis, what are we missing? What are we missing? What are the evidence for our theories? I think it's thyroid disease. Okay, so what is your evidence for that? Well, hypothyroidism presents with low mood. Hyperthyroidism presents with agitation. Hypothyroidism and hyperthyroidism present with fatigue. Okay, well that's interesting. Is there evidence to refute that? Yes, there is. What doesn't fully fit is the other question. Well, would her thyroid disorder suddenly come on or be significantly precipitated by the fact that she's just moved? Why doesn't she have any problems with weight gain? There are other things not missing here. There are things missing here, okay? So threat to patient or license. So yes, there's a couple of things here. She could have an ectopic pregnancy. She could have an infection. She could be a risk to herself or others based on her mood. What are we missing here? Well, we've not done a risk assessment because she's got fatigue and low mood, okay? We've not done a menstrual history properly. And we've not done an STI history either. Could she be pregnant? We don't know. Evidence for our theories, okay? So the demographic, the MSE, the social history, and a normal examination are all pointing in certain directions for what I colour-coded green and amber. What doesn't fully fit here? Well, there's no overt bleeding. There's no signs of malabsorption, so she's not got runny diarrhea and have an odd dietary habit. And she doesn't have many, if any, thyroid signs, okay? So some of the greens don't quite fit, okay? So let's do some investigations. And I've just put bedside bloods imaging special. And just by having a blank slide with this basic format, you get everyone in the group in the habit of saying, if I am going down an illness script, my illness script needs to be organised, bedside bloods imaging special. So I could say at the bedside, okay, I'm going to do some OBS, I'm going to do her BMs, her blood sugars, beta HCG, human chorionic gonadotrophin, okay, which is for pregnancy, and I'm going to do a urine dip, plus minus MSU if it comes up anything positive. In the bloods, I'm going to do some routine bloods. I'm also going to do my tired all the time bloods, TATT, which are the hematemics, which include iron deficiency anemia, B9, B12, and IgA-TTG, lipids, calcium, magnesium, CRP, ESR, so a whole set of things that I could do there, and I'll pick and choose what's necessary. Imaging, nothing at the moment. Am I going to do any special tests at the moment? No. So I've hidden that away, I've got the structure, and I've asked the group, what would you do? So we'd come up with a couple of things. Maybe you could say, all right, Bob, give me bedside. All right, Bobette, give me bloods, and so on. So the results come in now. So I'm going to break it down into 3 columns. The tests that we've got, their reference ranges, and here's a top tip. You should always give reference ranges. So never just give the number, always give the reference range. And then the results. So here come the results. And in most electronic medical records now, they glow red when they're out of range, either too high or too low. So I've done a couple that are out of range there, but not all of them. So this is a 28-year-old female with fatigue for 6 weeks who has low hemoglobin with low MCV, so a microcytic anemia. Ooh, look at my, you just vanished. Ooh. And then ferritin. So the ferritin is 8. So ferritin's low as well. Interesting, right? So what is that? What's going on there? Everything else is looking pretty good to me from here. Pretty good. So we're really sort of narrowing down these differentials now. So if we're bringing in what was the differential list, I think that we're getting to a diagnosis here, aren't we? So we've got, and let's just say that her folate and B12 were normal as well. So we're getting to a point now where it's an anemia and an iron deficiency anemia. So how are we going to manage this patient now? So I like to do A, B, C, D, E, and I even do this in clinic because it forces me to slow down and make sure that I cover the bases super easy. So A is advice, okay? So A for advice, let me write this down for you. So A for advice. B for biopsychosocial elements of the management plan. C for conservative management. D for danger, red flags. SOS, making sure that the red flags have been iterated so they know when to seek further help, and then E is to escalate. When to refer this to A&E, to AMU, to surgeons, to specialty clinic, what have you. So this is good in primary and in secondary care for holistic care and is excellent for OSCEs. So A, for advice, I'm going to give her a patient information leaflet on iron deficiency anemia. Here is a leaflet about this condition that you have so you can educate and empower yourself. For the biological, I'm going to give 200 milligrams of ferrous fumarate, alternate days because it's better for them to tolerate it, Monday, Wednesday, Friday, per oral. They should be bled at 6 weeks when they're normally normalized, if they don't have frank bleeding ongoing or overt bleeding ongoing, and then at 3 months, 3 months after normalized, it should be continued for. So 3 months after that, we will continue the course and then we will rebleed them. The psychosocial, so I'll do a GAD-7 and a PHQ-9. GAD-7 is a patient-reported scale for anxiety. PHQ-9 is for depression, so I could text them that so that they could fill it out, or I could do it with them. And that gives me a nice objective number of the extent of their anxiety and how it's affecting their quality of life and for their depression, so that with treatment, we can see if it improves. Then the social context, so continue to take a more detailed social history, see if we can deal about this occupation, what's going on, can we help in any way, can we refer you to the social prescriber, do you need further support with that, do you need a fit note for a bit of time off work, occupational health, is there anything that we can do to assist you there? And then C for the conservative, monitor mood ongoing and just let them know about the mental health first aid that they can do. You can give them some dietary advice, what kind of food contains iron that's really good for them, that's patient specific, so based on different cultures and based on, if they're vegetarian and the like. And then you can give them some ideas for apps or links to have period diaries if that's the thing that they're particularly worried about. Then the danger signs, so SOS iterated, so pointing out what happens if the iron deficiency anemia gets worse or if they notice bleeding and the like. Giving them some good red flags there, making sure that a follow-up is arranged for them and repeating of the blood form, okay? So that they, can take the form with them when they go and see the phlebotomist at week 6 and 3 months later. And then pointing out that there is red flags on the NHS Direct website, okay? So if you just type in NHS Direct and then the condition you diagnose a patient with, there is a wonderful free and simple website that works on mobiles, and my microphone's gone again, that works on all sorts of things. And there's very few pictures, so it loads super quick, so you don't need a quick internet connection, and it's really good. And at the bottom of the page, it usually has red flag warnings, so the patient can have a read of that if they're literate enough, and if not, you can print it. And then E is escalation, so I don't think we need to escalate this to a hematologist at the moment. I think they're okay. So A, B, C, D, E for how we've managed. And you can have the group come up with that. Maybe they could all go away and they could have one of each of the arms and then come back together and give their contribution. And you can say, oh, look, we have holistically managed this now. That's great. So if we're just looking at the bottom here, we're missing a couple of things. So we're missing, we're missing a couple of stuff. One of them just filled out there. So virtual primary care is something that we have a subscription to at the uni, and it's from the Medical Schools Council and SAPC, whatever that is. I don't know what that is. Come back. And so it has loads of videos. It's sort of like a fly on the wall, like Big Brother kind of camera. So you can see GPs doing consults for loads of the UK MLA. So it's actually really good. So you're seeing experts model these conditions. So we might watch a video of a patient presenting with fatigue and a history being taken on an iron deficiency anemia if that's present, right? Another thing that you can't discount here again in expert modeling is having your facilitator come up with a story. So you could turn to them and you could say, can you tell us, oh facilitator, oh doctor in the room, of a story of a patient with anemia or a fatigue patient that springs to mind with you and how you work through that reasoning process, because that is knowledge information and it's the salience. So you know it's important because here is a doctor saying how this knowledge and this thought process led to something happening, either a near miss, either a bad result or a good result, all of which gets that entorhinal cortex, as we talked about. Ooh, this is something I need to remember, so I'm going to listen to that. And then role play. So you can actually practice an OSCE. So you could say, okay, let's change that triage note and say that it's a 56-year-old female with known celiac disease and IBS who presents with tremor, fatigue, and increased weight that she can't take off for 6 months. How does that change everything? Okay, so blah, blah. So you can do a bit of role play. And then the final thing now, because we've addressed all of the pillars apart from pillar 1, which is about feedback, is Gottman, Miller, and writing. So just to refresh you of that, so you don't have to watch the other video again, Gottman talks about how there's negativity bias for feedback. We remember the negatives far more than the positives. Miller is that we overestimate short-term memory. There's no more than 4 to 7 chunks. And writing is always write down the feedback. The feedback being written down is so important, okay? Never just give it orally. So, if we shove all those at the top, then we can come up with the thing that I like to do, which is the pearls and progress notes. Okay, so even the negative thing, pearls and things to go away on, is framed as progress notes. So it's positive psychological feedback. Okay, this isn't just arty-farty, it does actually have evidence base to it. So pearls and progress notes. So start and finish with a positive, and sandwich in the middle 2 progress notes. Okay, so the first pearl, good use of bias checking, okay? You checked your framing bias, you looked at your affect and the context and time. Second good thing is that there was a good differential there. It wasn't just left, okay? It was revised at every single stage. When the exam came, it was revised. When the investigations came, it was revised. So that was all really good news. You didn't do a menstrual history, so just make sure you go and have a look at the OSCE notes to make sure that you have those clinical skills, that you can do a menstrual history. And make sure that you know clear dietary advice. So what dietary advice are you actually going to give this patient so that they can have some iron? And then clear structure in the investigations, which you did, which was great. So you did bedside, bloods, imaging, and special. So that was really good. And make sure that you stick to that. So just get in your head right now that whenever you're talking to a senior in the hospital on placement, whenever you're in your OSCEs, whether formative or summative, and they say, what would you do next? And it's investigations, the first words out of your mouth is, at the bedside I would do. The bloods I would order are this. The imaging I would do at this time, nothing. Special investigations, no. So make sure you, because the temptation is to jump, bedside, bloods, imaging, and special. Slow down to speed up, as they say. And one way that I have been experimenting with doing this with students is that, say I'm at the hospital and I'm doing some bedside teaching. When I do my pearls and progress notes, I will get out my phone and I will watch them. And I will, before they go and do the thing that I'm reviewing them on, whether it's a CBD or whatever, or a mini-CAX or a DOPS, I will give them my phone and I will say, put your email in the Outlook at the top and then I will make notes as they're doing it, and then I will send them that email. So I have a copy of the feedback, they have a copy of the feedback, and it's just done immediately, and you don't have to faff around with paper or whatever. So literally it's something as quick as, here's some feedback for you, Pearl, progress, Pearl. Thanks for coming today, let me know if there's anything you need, and my signature at the bottom so they know how to contact me. That's literally it. And if they need that feedback for a portfolio or whatever, they can copy and paste it in. I'm happy to put it in something else, but that makes it super quick. Like, it takes seconds to give them feedback, written feedback as well. So we've covered all the points of all 4 pillars in a very quick and simple case. This is the kind of case quality that you should be bringing to your CCT sessions, okay? So it's not too bad. I don't think that's too bad as a case, and just walking it through nice and slowly, making sure you have a structure. This is how you build those illness scripts. So good luck.